Okay,
Better?
perfect. Yeah.
Okay, great. So I'm going to talk about the approach to the patient with new seizures. I'm just thinking that this is a topic that this is, seizures in general will be covered, epilepsy will be covered, and kind of what you will be seeing somewhat in your day-to-day life, or certainly throughout your residency. So we're going to talk about some definitions, history and physical diagnostic tests, neuroimaging, EEG, as well as treatment. So what does the word seizure mean? So seizure derives from the Greek meaning to take hold, and it's a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain, or too much electricity, as I tend to say. And it can affect sensory, motor, and autonomic function, consciousness, emotional state, memory, cognition, or behavior. So depending upon where the abnormal electricity comes from is what systems are affected. So if it's the frontal lobe, you will have a motor seizure. If it's the parietal lobe, you'll have a sensory seizure. If it's part of the limbic system or our emotional system, then our emotional system will be involved during the seizure, like feelings of fear or feelings of sadness, etc. But epilepsy is a little different. So I'll give you some statistics on the next page just to reiterate these points, but about 10% of people over the course of their lives will have a seizure, which is a huge amount. But only 1% of those people about 1 to 2% go on to develop epilepsy. So epilepsy, besides being a very stigmatizing term, used to just mean number 1 on this list, which is having 2 seizures at least 24 hours apart. So when I was a resident, I remember going to see someone with a second seizure, and the ER doctors would say to me, they came in with a seizure last week, and I just told them to go home and come back after their second seizure. And I was like, well, at that time, which is many years ago, we couldn't really do much better than that. But they've revised the terminology since then. So yes, it means having 2 seizures greater than 24 hours apart. And of note, if you have 5 seizures in one day, that counts as 1. And if you have 5 seizures 24 hours later, that's your second. So they have to be greater than these 24 hours apart, even if they're clusters. But if you have a single seizure, and this is where it got more clear or just better, and the probability of having another seizure greater than 60%, then you should get treated, which is what this all means. Like, when do we treat people? When do we put them on medicines? So we treat people after they've had a single seizure, but a probability of having another seizure that's greater than 60%. And who is that? And I'll show you who are some cases, and it'll be clear. And you don't have to do some fancy calculations of like at what's 60%. It's obvious. And then the third diagnosis, a way to get to an epilepsy diagnosis, is if you have an epilepsy syndrome. So if you're a kid and you have a single absence seizure, like a little bit of spaciness, your chances of having another absence seizure are greater than 60%. And so after even just one absence seizure, we know that kids should probably be treated for epilepsy. Okay, so 1 in 10 people, or 10%, have a seizure over the course of their lifetime. About 1 in 26, or this is 2 to 3%, go on to develop epilepsy. About 3.4 million people in the US and 64 million in the world have epilepsy. About 3 million are adults and 1 million are aged 55 and older. So one of my residents now, who's going on to do her epilepsy fellowship, wants to do, there isn't one that exists, but almost like a super specialty fellowship in geriatric epilepsy, because seizures present in this population for the first time, not infrequently, which has a lot to do with etiology, because older people are getting strokes and older people are having more traumatic brain injuries. And so these are all possible causes for seizures. So pretty good to familiarize yourselves also just with the classification of seizures, mainly because we speak we use different words now to describe seizures. So we don't use the terms simple partial or complex partial anymore. Now we just use the terms focal aware and focal impaired aware, meaning if someone has a focal aware seizure, that they're aware of the twitching. You know, I have these seizures where my right arm just twitches and it lasts for about 1.5 minutes. That's a focal aware seizure. So they can talk to you, you can talk to them, they can follow commands. And a focal impaired aware is where it looks like, you know, their eyes are open and they might be kind of staring at something, but they're not responding. They can't tell you what the date is. They can't tell you what their name is, but they're not unconscious. Both of these can become or look like eventually a generalized seizure or a focal to bilateral tonic-clonic seizure. And as neurologists, we often ask, well, someone had a convulsion at the beginning, did their head or eyes turn in one direction? So what someone does when they have a seizure, we call it seizure semiology, just a fancy way of saying what someone does when they have a seizure. And we try to get a sense of if it started as a focal seizure and then became generalized. And believe it or not, most adults have focal seizures that generalize. They don't just have generalized onset seizures. Generalized onset seizures are much more common in children, and they can be tonic and then clonic, or other motor seizures. They can just be tonic, they can just be clonic. And non-motor generalized seizures is absence. Those are like everybody kind of has to memorize during medical school when they have, you know, these spacing out spells with 3 Hertz spike and wave or 3 per second spike and wave on the EEG. And then the last category, besides focal and generalized, is unknown. And that's if you don't see the onset, or you don't have the technology like an EEG to figure out if someone has focal or generalized seizures. So we just say unknown. And the reason this is important is because of what medication we give to the patient. So focal onset seizures can really take any anti-seizure medicine on the market. And they're about like 30 or even 35 these days. Whereas generalized onset seizure patients, you can only give about a handful of medicines to, because if you give them some of these other medicines that are just used to treat focal, you can make generalized onset seizures worse. Good news is most adults have focal onset and you can give them any medication out there, but obviously there are some that are more popular than others. So the difference between a focal and a generalized seizure is that a focal seizure starts within one hemisphere or one lobe or one place or focus. And then it may spread, but it starts in one place. Whereas generalized seizures originate at some point and rapidly engage both sides of the brain. And so with generalized seizures, there's usually no aura or warning. An aura is a focal aware seizure. And it just kind of 1 minute looks normal, and then the next minute, both sides are abnormally electrically firing, and people tend to have convulsions with it. Okay, so what are we trying to do with a new onset seizure? So we want to determine, one, if it's an acute symptomatic seizure, and they will never ever be an acronym for acute symptomatic seizure. And so the reason we want to know if it's an acute symptomatic seizure is oftentimes these people don't need long-term treatment. So in the hospital setting, we see a lot of acute symptomatic seizures. So people with hypoglycemia or hyperglycemia, people with hypokalemia, people with renal failure, liver failure, they might have jerky movements, hypoxic ischemia, you know, like there's a lot of things that can kind of cause an acute symptomatic seizure. So it means that it's in close temporal association with a transient central nervous system or systemic insult. So all of those things, including all those metabolic derangements, and it's presumed to be an acute manifestation of the insult. Traumatic brain injury. So there's other things that kind of fall under this umbrella term of acute symptomatic seizure. So if you have a traumatic brain injury, you're allowed to have a seizure within 7 days. If you have a stroke, you're allowed to have a seizure within 7 days, but outside of that 7-day mark, you're not, it's no longer an acute symptomatic seizure. Your predisposition to have recurrent seizures, within that, if it happens within 7 days, you don't receive long-term treatment for your seizures. You may treat someone for like a week or so, but if someone has a seizure after a TBI or a stroke or something that happens to their head, after 7 days of it, they get treated. If you see a patient who comes to the ER with hypoglycemia and having a seizure, you're not going to put them on Keppra. You're going to correct the underlying metabolic problem. Okay, single unprovoked seizures. So this is where sometimes the terms get a little bit confusing. So a single unprovoked seizure means that there is an absence of precipitating factors that may be caused by a static or progressive injury. So you can't find a cause. In other words, an alcoholic comes in after not drinking, that would be considered a provoked seizure, right? It's alcohol withdrawal. Someone who comes in, you can't find a toxic metabolic derangement. You can't find an infectious cause. You can't find the acute TBI or the acute stroke. And they have a first-time seizure, and you don't have a cause, that is their first or single unprovoked seizure. And those terms are kind of hard to sort, what's provoked, what's unprovoked. If there is an underlying cause, it's provoked. If there's not an underlying cause, it's not provoked. However, this is where the caveat. So there may be an old stroke or an old TBI, not a new one. And at that point, if it's past the 7-day mark, it's not considered provoked anymore or acute symptomatic due to the injury. So if you had a TBI 10 years ago, and then you had your first seizure, that would be a first unprovoked seizure because nothing really changed that caused it. Okay, and then the other thing you're trying to differentiate when you see someone with a seizure is whether it's a non-epileptic event. So this last slide is a little bit old to look at, kind of like when you see someone who has a seizure-like spell, like what does that mean? Is it, in this term, non-epileptic? We usually use the term non-epileptic to mean psychogenic, the third thing here, but we try not to use the word psychogenic because we try not to use words that have the word psycho in it when we give people diagnoses. So we say a non-epileptic seizure, but is it syncopal, right? Is this cardiac for what happened to them, like a convulsive syncope where they really did have a cardiac event, but they had some convulsive movements with it? Is this a migraine? Is it toxic, metabolic? Is it cerebrovascular? Is it due to a stroke? A tremor, sometimes tremors can look like seizures, but a tremor you can actually suppress, right? If you move someone, if they're having a tremor, and a seizure, you can't suppress a seizure. You'll feel somebody jerking if it's a seizure. Or movement disorder, another type of movement disorder. And then, of course, if it's epileptic, we're going to do just what we did on the first couple slides, is decide whether it's a generalized seizure, a focal seizure, or unknown etiology. Okay, so you see a patient with a seizure. The first thing you do is you take a history from them, but the best person to take a history from is a witness, because oftentimes people don't remember what happened to them during a seizure. I call this doing my job, because after you've talked to someone for 20, 30 minutes, 40 minutes, and then you're like, okay, can I call the person that saw the event? Because it's like that extra step, but it actually makes a huge difference in figuring out if this was a seizure or this was like a fainting spell or something else. And then as part of the history, we're going to go through, we go through a lot of these things. And this is even different than any kind of neuro history. I call it a special seizure neuro history, because we ask things like if they were premature, because if you were born premature, in some cases, there's more likelihood of an intracerebral hemorrhage, which could be a source of seizures later on. Also, why were you born premature, right? What was there something going on, like some trauma with mom, whatever it is? Developmental milestones, so walking on time and talking on time. Febrile seizures, so most febrile seizures are genetic. Most people with febrile seizures outgrow them. You would never remember if you had a febrile seizure because you're an infant. So you have to go back and ask the parents. I saw a kid like a year or two ago, and I asked the parents if they had febrile seizures, and they were like, no, we don't know what you're talking about. I was like, well, go and ask your parents. And both of them came back to me and said they both had febrile seizures. So it's very common to see febrile seizures in parents who have had febrile seizures. And a certain percentage of kids that have had febrile seizures do go on 20, 30 years later to develop epilepsy, but only in about 10%. So it is a risk factor. Obviously having meningitis, encephalitis, having a family history of seizures or epilepsy, and then these are all sort of acquired, throughout the course of your life risk factors for seizures and epilepsy: stroke, TBI, neurodegenerative disorders like Alzheimer's, alcoholism, even if it's not due to withdrawal seizures. Being an alcoholic does predispose you to developing epilepsy later on. Alcohol is an epileptogenic substance, and of course, brain tumors. This is my seizure review of systems, so different than your review of systems. So I asked if they were the spacey kid, trying to see if they've had absence seizures, if they had early morning jerks. These usually you see in 20-year-olds who present with their first time seizure. So you'll get a history of they tend to drop their toothbrush in the morning, or soap, or their spoon with their cereal. They get these little jerky movements, and then usually present after a generalized tonic-clonic seizure, and that's in juvenile myoclonic epilepsy. If someone has excessive daytime sleepiness, which I'm sure we all have, but if it's like I've been getting 10 hours of sleep every single night for the past month, and you're still exhausted, besides sleep apnea, you wonder if there's a seizure thing going on there. If you wake up obviously with your muscles sore, having bitten your tongue, having been incontinent of urine, funny smells or tastes like chemical or metallic, deja vu, feeling like you've been somewhere before, which we've all had and is not a seizure, but if you have it every day or once a week, then it's abnormal. But every time I have deja vu, I'm like, my hippocampus is just misfiring, but it's okay, and you get on with your life. Jamais vu is also a seizure, sort of kind of hint that someone's having seizures. You go someplace very familiar, like your room, and you're like, where am I? And this place looks unfamiliar to me. So that's what jamais vu is. A warm rising epigastric sensation. So this sort of I had a patient describe it as a melancholy that just kind of overwhelmed him, and it would last for a couple seconds. It's not, people often mistake it for GERD. I'm like, GERD is not a seizure. Dissociative feeling, so feeling like you're outside yourself, looking down. And lost time, meaning you start out in one place, you get to someplace else, and you have no idea how you got there. So these are all things that could be seizures that as human beings, we tend to fold into the background of who we are as people, but are really abnormal things. Okay, an aura is a small seizure and usually indicative of focal epilepsy. So we always want to take surgical history. Obviously, if they have a history of a brain tumor or a vascular malformation, a subdural hematoma, these are all risk factors for seizures. And then there are medications that reduce the seizure threshold. So you'll come across this where you'll, call a neurology consult for a medicine patient, and they'll say, well, can you, take the patient off of this medicine because it does lower the seizure threshold or make the patient more prone to seizures. So certain antibiotics like the cephalosporins, fluoroquinolones, anything that ends in imipenem or penem is seizurific. In my world, so seizure disorders and mood disorders run together because it's the same real estate. So we have a lot of patients who have depression and anxiety, and if they come to you on bupropion and they have had a first-time seizure, you take them off bupropion or Wellbutrin. It's a big no-no, but that's the only one really. All other antidepressants are okay for the most part. And tramadol. Tramadol can definitely cause seizures. Okay, so the diagnosis is a clinical one based on history and physical, right? So we don't, our way of diagnosing these things with MRI and EEG are just surrogates. We have so many people with normal looking MRIs and normal looking EEGs that have epilepsy. This is a fact. It's an unfortunate fact because people always want to have the proof, but it is a clinical diagnosis. Physical exam. So these are just some statistics, or a couple statistics, but other things to look out for. So lateral tongue bites are seen in about 22% of patients with all types of epileptic seizures. So if you see a lateral tongue bite, you have to be highly suspicious. A Todd's paralysis, which means weakness on one side after a seizure, usually means that's the opposite side of the brain is where the seizure came from. Nuchal rigidity, so you want to, of course, for meningitis encephalitis, want to look for nuchal rigidity, and asterixis. They're a toxic metabolic cause. Okay, so what do we got? We have their basic diagnostic tools like blood tests, right, to look for any metabolic derangements. Infection, we don't spinal tap everybody who comes in, or lumbar puncture everybody who has a new onset seizure, but if they have any meningismus, we do. I don't know if any of you have read or seen the movie Brain on Fire. I'm trying to look at your faces. Has anyone seen it? Yeah, Victor.
It's a really good movie.
It's a really good, right?
Yeah, it is.
So it is a good movie. It is actually also a great book. It's a great book. So these are people who come in with new onset seizures, usually in the setting of kind of a rumbling psychiatric illness, like psychosis, paranoia, depression, and a movement disorder is usually like sort of the triad that goes with it, and they get spinal taps. Prolactin we don't check because you need a baseline prolactin usually for that to make any sense. And with syncope, you can get quite an elevated prolactin. I actually saw a patient the other day who came to me, was like, I had a seizure because my prolactin was elevated, which all she really had was like a convulsive syncope. Neuroimaging, if someone hits their head, we do a CT of their head, but someone who's coming into the ER with recurrent seizures, we don't do a CAT scan every time. And an MRI is part of the initial workup or if something changes. And then of course, EEG. So just a couple of words on prolactin, just because I've seen it done, but it does potentially differentiate generalized or focal seizures with impaired consciousness from non-epileptic events. So that's the biggest thing. If someone comes in with what was called psychogenic or non-epileptic seizures, and something that is an electrical seizure, must be measured 10 to 20 minutes after the suspected event. So this is usually the rate limiting step. Must be compared with the patient's baseline prolactin, which is measured at least 6 hours prior, which again is not happening in an ER setting, but may happen at baseline. And then prolactin elevations can also be seen with syncope and cannot differentiate between an epileptic seizure and syncope. So emergent imaging. So when do you get a CAT scan? So if you suspect someone has a brain lesion, you absolutely do it. If they have new neurological deficits, yes. Persistent altered mental status, recent trauma, or prolonged headache. So these are people who get emergent imaging. Someone who has a seizure disorder who comes in with their typical seizure, and has not hit their head, you don't need to do a CAT scan. So this is going to kind of tie into some of the things I said earlier. So CT head. So you have a 58-year-old left-handed woman who presented with right leg spasms, followed by a scream, loss of awareness, and full body convulsions with foaming at the mouth. And her CAT scan showed on the left, in her frontal lobe, this big hyperintense lesion, as well as all this edema around it. And she had a huge meningioma here. So this was a first-time seizure. This isn't the kind of person that we're going to say, go home and just come back after you have the second seizure, obviously. She went for neurosurgery. She had the meningioma resected, but she also got placed on medication after this first seizure. So the 60% literature comes from meningioma. So if you see a meningioma on a CAT scan or an MRI in someone with a first-time seizure, their risk of having another seizure is greater than 60%. We've kind of extrapolated from that and said, really anyone who has any kind of brain lesion, if they have like a tumor, a big tumor you see, it doesn't have to be a meningioma. If you see a traumatic brain injury and you see a cortical lesion, you're going to treat that person after a first-time seizure. Okay. What a CAT scan can miss are low-grade gliomas, hippocampal sclerosis, which is so our memory centers that live deep down in the brain, they get scar tissued in some people, and hippocampal sclerosis is the most common etiology of seizures or epilepsy in adulthood. So they get temporal lobe seizures due to mesial temporal sclerosis. So any kind of cavernous malformation, so small cavernous malformations can be missed on a CAT scan, and malformations of cortical development. So a cortical dysplasia or a periventricular heterotopia. So these are things when we are in utero, our gray matter actually sits right outside of our ventricles. And then all these hormones tell our gray matter to migrate out to the cortex, which is where it lives for the most part. But some pieces can get stuck if it didn't get the memo. And if those pieces sort of get lodged in the white matter, they're a tremendous source of epilepsy later in life. And people don't know they can live with them until their 30s and 40s. And they're like, how could I have, not known about this? But this is a not uncommon way to present with epilepsy later in life. Okay, MRI. So I know this isn't the best picture, but there is, my circle is going to show it. So the gray matter, which looks more white here, is on the outside of the brain. And you can see there's a little piece right around, this is the lateral ventricle. It's an uneven cut, but there is a little hunk of gray matter sitting outside the ventricle, and that can be a cause of seizures. So at Mount Sinai, I've had the pleasure of working with Preeti Balchandani. She's at the Friedman Brain Institute. And she has a 7 Tesla MRI. So most MRIs are 1.5 or 3 Tesla. But we did some work together many years ago where we stuck patients who had normal 3 Tesla MRIs or 1.5 Teslas into the 7 Tesla MRI. And in about 20% of patients, we actually found abnormalities that you couldn't see just with your clinical scan. Okay, EEG. So I don't know if anyone remembers from medical school what this EEG is of. You want to guess? Bring you back? Nobody, it's okay. Okay, I'll ask, this is totally, if anyone gets this, I will be so impressed and have to steal you to neurology to become an epilepsy doctor. But can anyone guess if this is, I know you're just like, you'll be familiar with the bottom line, right? The EKG. So this, this tracing. And not to say we're more complicated like humans to be able to like interpret these lines, but like, it's not that hard. It's just a pattern recognition. But this is, if you believe me that this is normal, these sinusoidal waves are like very normal appearing, and these sinusoidal waves are very normal appearing, and this big thing in the middle is abnormal appearing. Is it generalized or focal? What do you think? If you had to guess, if I'm telling you these electrodes are over all the brain, what do you think? Generalized, yes, absolutely. So this is a generalized discharge, and it happens to be 3 Hertz spike and wave, which is the absence seizures, but this is you could see the whole page is just filled with spikes. Okay, so when do you do an EEG? So non-emergent EEG, which is what we normally do, it can help differentiate seizure types. So if we saw that EEG, which was a routine EEG, I'd say that person has generalized seizures. In patients with new onset seizures, 29% will have epileptiform abnormalities on their first EEG, which is a super small percent. However, this is sort of the important part, there's a slightly higher yield of catching the seizure waves on an EEG if it's performed in patients within 24 to 48 hours of a new onset seizure. So there is a little bit of urgency in trying to get a new onset seizure patient in for an EEG to try to prove or disprove whether or not they have epilepsy. But this is just routine EEG. So when do you admit someone though and get more or continuous EEG monitoring is someone who has a new onset seizure but does not return to baseline after 30 to 60 minutes from the seizure end time, if their mental status waxes and wanes, or if they have focal dysfunction unexplained by a structural lesion. So you see a little something, but you're like, it doesn't add up. Like there's a little something here, but this person is totally altered. Okay, so these are some cases I borrowed from medicine. So this is a 50-year-old man with diabetes who presents with 2 convulsive seizures in the setting of hyperglycemia to the 400s. On exam though, he's totally inattentive and perseverative. He's episodes of speech arrest with chewing, mouth movements, and horizontal nystagmus. In between these episodes, though, he's able to answer questions, and this is taken directly from the neuroresident's note, which was albeit in odd ways. For example, when she asked, "How old are you?" he responded in Earth years. So this was his CAT scan. He had an emergent CAT scan, which was totally fine. There's no, unlike that previous woman with that big meningioma, there's nothing that we could see on his CAT scan. And then because now you're EEG experts, you can tell that his background, you know, you see those sinusoidal waves. There's no big, huge spikes. But I'm going to show you. So he was admitted to medicine, which often happens when people have hyperglycemia to the 400s. Neurologists don't like to deal with that. So he's kind of lying in bed. No one at this point is really talking to him. And, oh, sorry, I'm going to go back. In fact, I'm going to tell you, even though I cut off where the electrodes are placed, just to give you a sense, I'm going to skip ahead. So, no, I'm not. Okay, I have no choice. You're going to have to be tortured with this again. Okay, so I swear I'm going to give up after this. I'm not, my hands are up. Okay, so the first 4 lines represent the left temporal, sort of the electrodes over the left temporal lobe. The next 4 lines are the homologous region over the right temporal lobe. Okay, so these 4 and these 4 should look identical because, like we are on the surface, our right side and left sided body, right? You can't tell the difference. Now, these next 4 lines are over the left top of the head, and these next 4 over the right top of the head. So these 4 and these 4 are on the right. And can you appreciate that there's a little bit of a difference between these right-sided electrodes and these left-sided electrodes? Or you guys, do you think I'm hallucinating? A little bit. It's not as obvious as the other cases, but what had kind of happened is these got a little bit higher in amplitude and a little bit faster in frequency. And now if you can appreciate, there's a little bit of, they kind of slowed down. Everything just got a little bit slower, like and wonkier. And he's seizing. I mean, he's not there. Maybe he's having, you know, he's kind of like, poor guy, like stretching a little bit in the bed, but like he didn't really do anything that obvious. But that was a seizure. And we've had a number of cases over, like, I'd say within just, I can think of 3 off the top of my head over the last, and since this academic year, where these guys have come in and you can see now everything's kind of flat. So the patterns on these waves changed from just over several seconds. He didn't really do anything that obvious, but he was in status epilepticus, full-blown non-convulsive status epilepticus, which was, I mean, we don't say subclinical because he was clinical. He was altered. he doesn't normally act like Earth years. Like he's a totally normal functioning guy, but his mental status was altered because of these seizures. Okay. MRI brain. This is actually his MRI. So you can see, if you can appreciate this. So this is the right side, this is the left side. You guys know all this. There's a little bit of cortical ribboning here on the right. So if we look at the diffusion weighted images, which are often, we look at strokes for that, you can often see cortical ribboning when people are seizing from that side. Okay, so in patients with subclinical seizures, although I wouldn't call his subclinical, I would call his non-convulsive, because he wasn't convulsing, but he was certainly clinical. Less than 50% are detected by routine 30-minute EEG monitoring, but the yield increases to greater than 90% with 24 to 36 hours of continuous EEG monitoring in patients with an acute brain injury and mental status change. So he would fit into that. So if you see an acute change in mental status, you cannot account for it on a CAT scan. You can clearly see something on an MRI, but obviously you're like, where would that come from? You should get an EEG and connect that patient to long-term monitoring. So there is an approximately 35% chance of a seizure reoccurrence within 5 years following a new onset seizure in adults. And in persons who have had a second seizure, the risk of a recurrent seizure increases to 75% during the following 5 years. So this is someone who's had 2 unprovoked seizures. That's why we treat the second unprovoked seizure. Okay, so the management of a first unprovoked seizure, there's some guidelines, which basically says if you've had a previous TBI, if you have an EEG, routine or long-term, that shows any seizure waves, and you have or a brain imaging abnormality, right, a meningioma, and lastly, a nocturnal seizure, so a seizure out of sleep, even if it's just one, you get treated with medicine. So this is who do you treat? Anybody who falls into any of these categories: previous TBI, seizure out of sleep, abnormal EEG, abnormal MRI. Okay, and this is just a really nice algorithm I took from this article. I think it was a JAMA article, just basically saying, trying to give you a sense of like how to go through the person with seizure. So possible new onset seizure. Is the event description and witness report suggestive? If it's not, look for something else. If the witness says yes, you get a history and perform a physical. Obviously, you're going to do this anyway. Is there evidence of a fever, focal deficit, or mental status change? Yes. Then you're going to go to your urgent CAT scan, your laboratory testing. You're going to urgent evaluation for acute symptomatic seizure, obviously, and inpatient admission. If no, there is no evidence of fever, focal deficit, or mental status change, you want to know if there's evidence of provoking factors. So is there sleep deprivation, alcohol use, medications, or drugs? Yes, but they get a non-urgent evaluation for acute symptomatic seizure. Similar workup, but a little bit different, right? They get the lab testing and a brain CT, not urgent, and an outpatient EEG, not inpatient one. Management, obviously, you talk to them about lifestyle modifications and you defer anti-epileptic medications if it's a provoked seizure. But if you determine it's an unprovoked seizure, you get an EEG, hopefully within 24 to 48 hours, and an epilepsy protocol MRI. And if they are abnormal results, they have epilepsy. So choose a first-line anti-epileptic medication. And if not, it's a first unprovoked seizure, and you may defer medical management. So this is the brain on fire. So this is a paper that came out last year. I think it was last year. Yep. So I thought it's interesting, and that new onset focal seizures, about 10% of the time, are actually due to an autoantibody. So this unknown group is kind of expanding, and we're finding that more people who were like, cryptogenic or unknown cause in adulthood actually probably have an autoantibody. But you have to look. It's a blood test, and it's a spinal tap. So it's a bit of a workup. It's also a CAT scan of your chest, abdomen, and pelvis, and a PET scan of your brain. So it's not just a little workup, it's a big workup. If you suspect it though, so I had a patient recently who has a history of anxiety starting in 2017, treated by a therapist. And she was like, you know, your anxiety is a little weird, get a routine EEG, which I thought was great. And this was back in 2017. Her routine EEG was normal. She continued to have once a week these like anxiety attacks. What was interesting about her anxiety attack, which I think I'll put here. So one is she was about 56. She had ictal piloerection. So if you get goosebumps, that's actually more likely to be ictal than non-ictal. So I'd say about every year I see about 5 patients who had been diagnosed with anxiety who have seizures. But that's always a thing. So if they get piloerection with it, like goosebumps, more likely to be ictal. If they have self-reported low mood, reduced attention, and if an MRI shows limbic system changes, usually hyperintensities, and the absence of conventional epilepsy risk factors. So always my antenna would go up if you see someone with like anxiety, new onset anxiety, who's kind of presenting, who just ask about goosebumps, and if they're greater than 50, it's something to think about. So usually it's, you know, when you think about anxiety attacks or anxiety, you know, you think about like pins and needles and hyperventilation. It's not like that. This is usually just like a wave of anxiety, and then they might get goosebumps, and often will complain of cognitive changes like memory deficits. Okay. So there's a lot of ways to look at medication, and I'm not going to go through them because it's like a whole other lecture in and of itself. But we touched upon this before that, you know, there are some broad spectrum medicines. These are for generalized seizures. We don't use about 50% of these. Like, how have you guys ever, like primidone, rufinamide, zonisamide? Like, there's some things on this list that can be used for generalized seizures, but you're not gonna start to use them. Felbamate, God forbid. Like, you're not doing these things. But focal seizures, these are for the most part more familiar, obviously. So you can divide seizure medicines. This is just kind of a slide. So you can divide by focal, you know, meds. You can divide by general meds. You can also, I made this slide. I'm getting tired of it, but you want to take these things into consideration when you're considering like what medicine to put someone on. So if they're older, you might want to stay away from certain medicines like trileptal or Tegretol, which can cause hyponatremia. If they're a woman of childbearing age, you don't want to put them on Depakote, things like that. Seizure type, obviously, we just talked about if it's generalized or focal. Again, women of childbearing age, you don't want to put, also Topamax is a big no-no. Newly diagnosed, or if they're refractory, are you adding on like your third medicine, or are you just, you know, starting a new one? What medicines, anti-seizure medicines they've tried or are currently on is going to dictate what you put on next. There's an idea called rational polytherapy. So you have to know all the mechanisms of all the drugs. I make all my residents learn them. So because you don't want to stick 2 sodium channel blockers on, you want to stick 1 sodium channel, maybe 1 calcium channel. You want to try, you know, different things. You also have to be careful of other medications. So hepatic enzyme inducers like phenytoin, phenobarbital, carbamazepine will interfere with anything else you have your patient on, like a diabetic med. It will interfere with immunosuppressants. It will interfere with a lot of other medicines, statins. So all these older meds will affect a lot of medications that patients are on. Comorbidities. Sometimes we can do like gabapentin that helps with neuropathy and seizures. So thinking about things like that. Long-term side effects, all the older medicines can cause bone marrow loss. So if you have a patient on anti-seizure medicine that's on phenytoin, carbamazepine, phenobarbital, or Depakote, you want to do a bone density scan to make sure they don't have osteoporosis. Genetics, and these are my references. That's it.